All right, welcome, doctors, to this board review explainer on dry eye syndrome. I'm your host, and today we're putting on our attending physician hats. We're not just going to sit here and memorize disconnected facts. We are going to build true clinical mastery of a disease that you are literally going to see every single day in your clinics. Dry eye syndrome, or DES, affects an estimated 10% or even more of the adult population. I mean, we've all seen her, right? The 55-year-old female patient presenting with that gritty, burning sensation that just keeps getting worse throughout the day. Do not underestimate her symptoms. Studies actually show that moderate to severe DES impacts a patient's quality of life to the exact same degree as moderate to severe angina. It is a massive clinical burden, particularly for our female patients. So we need to completely understand it from the cellular level all the way to the slit lamp. Okay, here's our roadmap for today's explainer. We're going to cover normal tear film anatomy, the lacrimal functional unit, the pathophysiology of hyperosmolarity, mechanisms of dry eye, the vicious inflammatory cycle, and finally, clinical management and pearls. Now notice the sequence here. We are following a strict biological progression. Normal anatomy dictates normal physiology, which when it gets disrupted leads to pathophysiology, structural change, and ultimately our clinical management. No isolated facts today, just one continuous clinical story.
Okay, let's dive right into this with Section 1, Normal Tear Film Anatomy. Because let's face it, you can't fix a broken system if you don't actually know how it's supposed to work in the first place.
Listen, first rule of the tear film for your Oak board exams, you've got to firmly discard that obsolete tripartite model. You might have been taught the old 3-layer model of distinct mucus, aqueous, and lipid layers, but actually, scratch that. It's no longer the scientific consensus. The modern, highly testable framework that you absolutely must understand is the 2-phase model. In this model, the aqueous and mucus intermix into a single gel-like layer known as the muco-aqueous phase, and this whole thing is covered by an outer lipid phase. So let's orient ourselves to exactly how this actually looks biologically. Down at the base there, that is your corneal epithelium. Now, the ocular surface is naturally highly hydrophobic, right? It totally repels water. So how in the world do we keep tears on it? Well, it's like a giant biological puzzle. The conjunctival goblet cells secrete mucin, which acts as this brilliant amphiphilic bridge. The mucin binds to the hydrophobic epithelium on one end, and it mixes with the aqueous on the other, creating that gel-like muco-aqueous layer you're seeing right in the middle. Finally, resting on top is the meibum, the lipid layer produced by the meibomian glands. This lipid sealing is absolutely crucial. It limits evaporation and provides that glassy smooth refracting surface we desperately need for crisp visual acuity. So the anatomy gives us the structure, which brings us to Section 2, the lacrimal functional unit, or LFU. This is what actually regulates the production of these tears. Think of the LFU as this incredibly dynamic reflex arc. Now, I want you to pause for a second here. Use some active recall. Before we trace this out, which cranial nerve mediates the efferent motor limb to the orbicularis oculi muscle? Did you say cranial nerve 7? If so, you hit the nail on the head. Let's trace the arc chronologically. An insult hits the ocular surface, triggering nociceptors in the afferent sensory limb. That's branches of V1 and V2. This signal shoots straight to the integration center in the brainstem. The brainstem then fires right back via the efferent motor limb, utilizing parasympathetics to stimulate the lacrimal, meibomian, and goblet glands, and cranial nerve 7 to contract the orbicularis to make you blink. Afferent, integration, efferent, effector. It's a beautiful system. All right, moving on to Section 3, pathophysiology of hyperosmolarity. We've got our normal anatomy and normal physiologic reflex arc established, so now we are moving into the inciting insult of all dry eye syndrome. This is exactly where the pathology begins. You're going to want to write this number down. It is an absolute OCAP pearl. Normal tear osmolarity is 296 plus or minus 10 milliosmoles per liter. Now, osmolarity is simply the concentration of solutes in a fluid. In dry eye syndrome, this number shoots way up. Why? Well, because if your tear volume is inadequate, the solute particles you do have are suddenly dissolved in a much smaller amount of fluid. Less fluid means a higher concentration of particles, which means a much higher osmolarity. So, okay, the tear film is hyperosmolar, but why exactly does that actually cause surface damage? Stop and think about the fundamental rule of semi-permeable membranes from a way back in med school. What is the rule? The membranes of our corneal epithelial cells are permeable to water, but not to solutes. And the golden rule is, solvent follows solute. When the tear film becomes hyperosmolar, it creates an osmotic gradient that literally pulls water right out of the underlying epithelial cells. This dehydrates the cells, causing extreme intracellular stress. Which brings us to Section 4, Mechanisms of Dry Eye. This hyperosmolar stress is the universal starting point for surface damage. But how do we get to that state in the first place? Let's introduce the 3 core etiologies. Now listen up, because this is a classic board trap. How do we clinically diagnose an aqueous tear deficiency, or ATD? We use these 3 specific tests, and you absolutely must know the difference between them. The basal secretion test uses an anesthetic before placing the strip, isolating only your baseline tear production. Less than 3 millimeters at 5 minutes means ATD. Schirmer I uses no anesthetic, meaning the strip irritates the eye, so it measures both basal and reflex secretion. Schirmer II uses an anesthetic on the eye, but then we intentionally irritate the nasal mucosa with a cotton tip to isolate reflex secretion only. An easy way to remember this? Schirmer I has one goal: measure it all without drops. Schirmer II uses 2 steps: drops, then nasal irritation. Understand the protocol, and the clinical interpretation becomes totally obvious. Clinically, we have to contrast these underlying mechanisms. Aqueous tear deficiency, that's a volume problem. This can be Sjogren's, which is an autoimmune lymphocytic infiltration of the lacrimal glands, or it can be non-Sjogren's, often caused by an afferent reflex block from contact lens wear, or efferent failure due to systemic anticholinergic drugs like antidepressants. Evaporative dry eye, on the other hand, is basically a lipid or mechanical problem. The aqueous is perfectly fine, but it's evaporating way too fast, primarily due to intrinsic meibomian gland dysfunction or mechanical exposure. Let's actually look at the pathology right on the patient's face. On the left, you're seeing mechanical exposure driving evaporative dry eye. This patient has thyroid eye disease. Just note the widened lid fissure, lid retraction, and exophthalmos. The tears are just evaporating straight off the globe. On the right, we see tear film instability. This is a Batot spot, a foamy white area on the conjunctiva classic for hypovitaminosis A. Vitamin A deficiency destroys the goblet cells. And remember, no goblet cells means no mucin. No mucin means the aqueous simply cannot stick to the hydrophobic epithelium, leading to instant tear film instability and dry spots. And all of this brilliantly illustrates how anatomy, physiology, and mechanisms all converge. Which leads us into Section 5, the vicious inflammatory cycle. The initial stressor always leads back to hyperosmolarity, and hyperosmolarity triggers a self-perpetuating pathological cascade. Let's map out this vicious cascade step by step. It kicks off when hyperosmolarity dehydrates and stresses the cells. This stress causes direct epithelial damage. In response, those damaged cells basically scream for help by releasing inflammatory cytokines, specifically TNF, IL-1, and MMP9. Here is a huge pearl for you. MMP9 actually cleaves epithelial cells right off their basement membrane, while TNF induces apoptosis. As these cytokines flood the tissue, they chemically disrupt the afferent neural reflex arc of our lacrimal functional unit. With the reflex arc blocked, the brain simply stops sending the signal to produce tears, resulting in decreased aqueous. And what does decreased aqueous cause? Yep, even worse hyperosmolarity. The cycle literally feeds itself. So our job as clinicians is to break that cycle. Let's shift to Section 6, clinical management and pearls. We don't just throw drops at a patient blindly, right? We tie our treatments directly back to the pathophysiological steps we want to interrupt. If your patient has evaporative dry eye driven by meibomian gland dysfunction, the absolute mainstay of treatment is lid hygiene. But why? Well, let's use an analogy. Normal meibomum is a liquid at body temperature. It flows easily out of the glands, kind of like clear drops of vegetable oil. But in MGD, the chemical composition of the lipid alters, raising its melting point. It becomes a semi-solid at body temperature, pushing out of the glands looking like thick toothpaste. It totally obstructs the gland and provides zero evaporative protection. This is exactly why we prescribe heat, to raise the temperature and melt that abnormal meibomum back into a liquid, followed by mechanical massage to express it out. Now, what does clinical success actually look like in the real world? Notice this beautifully healthy lid margin. You can see the normal meibomium resting right at the gland orifices. It is perfectly clear, liquid, and flowing freely, just like those drops of oil we talked about. When you compress a patient's lids at the slit lamp, this clear flow is exactly what you want to see, proving that the lipid layer is actively protecting the muco-aqueous phase right below it. All right, let's finish up with a rapid-fire review of your absolute highest yield testable board pearls. You need to lock these into your long-term memory. Number 1, the 2-phase model of the tear film is the modern standard, mucoaqueous and lipid. Number 2, normal tear osmolarity is 296 plus or minus 10 milliosmoles per liter. Number 3, topical preservatives, especially BAK, are notorious for causing goblet cell apoptosis, destroying your mucin layer. Number 4, remember that MMP9 is the cytokine that specifically cleaves epithelial cells right off their basement membrane. And finally, superior limbic keratoconjunctivitis, or SLK, is classically linked to mechanical friction from tight superior lids in thyroid eye disease.
So the crucial takeaway here is that by truly understanding the biology, you can logically deduce the diagnosis and the treatment. But I'm going to leave you with a final, slightly provocative thought. We know that high androgen to estrogen ratios are protective, while low ratios exacerbate dry eye, which is exactly why DES disproportionately affects our female patients. But how exactly do these systemic hormones modulate the lacrimal functional unit at the cellular level to dictate this entire vicious cascade? That is a totally fascinating piece of physiology, and it's exactly the kind of deep dive we'll tackle in our next explainer. Keep studying the structure, keep mastering the biology, and I'll catch you next time.